How many of you are doing neonatal or pediatric cardiac ECMO? Can you raise your hands? 2, 3. Okay, thank you. So in our center in University Hospitals of Leicester, we do around 95% of respiratory ECMO and approximately 5% of cardiac ECMO. I will take you through the indications for pediatric and neonatal cardiac ECMO and how the outcomes are going to be on this. As we have been talking in the last couple of days, we only think of ECMO after effectively utilizing available medical options, afterload reduction therapies, right balance of inotropes and lucitropes are being maintained and at the right point of time without delay. It is an option available with us. So that is the advantage, but we do think about it when all the other medical options have been ticked off. Who needs cardiac ECMO? As you all know, post-operative cardiac surgery wise, if a child cannot come off cardiopulmonary bypass at the extent of a complicated procedure or a long-standing procedure, if they fail to come off, that is one of the commonest indications why they need ECMO. Probably this is the best indication as well because the outcomes are the best in this group. ECMO as cardiac support, anticipating recovery and stabilization for a definitive cardiac procedure in an unstable child. One of the examples for this is a very difficult case of transposition of great arteries awaiting for atrial septostomy, but if the child's pH is very low, less than 7, with metabolic acidosis developing at that time, hyperlactatemia, if he is very poorly, probably poking the child for the sake of cannulation and doing the procedure of atrial septostomy might be detrimental. They don't tolerate well. So in those cases, we tend to put them on ECMO initially, stabilize them, and then take them through the procedure of atrial septostomy. Myocarditis is another known indication. Cardiomyopathies, so some of them do get better if they are transient, like secondary to vitamin D deficiency or at times idiopathic, or it can be used as a bridge for the next procedure. Arrhythmias are some of them don't respond to any amount of antiarrhythmic medications, and as our antiarrhythmic medications are myocardial depressants, their ejection fraction goes down and they end up in low cardiac output syndrome. So these are the other cases which will benefit from ECMO support. ECPR and non-heart beating organ donation, these are the cardiac indications for ECMO. This also gives another option. If the surgery is inadequate, go back, revisit at the right time and correct the surgery when the child is stable. During to achieve this, cardiac catheterization, CT angio, echocardiograms, they help us if there are any residual lesions which need to be corrected. So that is quite useful for that process. Actually, cardiac ECMO was the first one which was started in 1970, even prior to Bob Bartler's first case. Bob did his first case in 1975. The ECMO was used for supporting a case of congenital heart disease transiently in 1970 for a relatively short period of time by Dr. Baffes. And afterwards, it was used for slightly prolonged period of time for a couple of days in a 4-year-old child weaned after 48 hours and child was extubated 2 days later. This was by Dr. Suter in 1973. So historically, cardiac ECMO was the first one to be started before respiratory ECMO. Internationally, there's a lot of experience available. In the neonatal cardiacs, you can see close to 5,000 procedures have been done, and 61% is the outcome. In ECPRs, around 63% is the outcome. In pediatric wise, cardiacs, they have achieved better figures, which is nearly 65% outcomes, and ECPR around 54% outcomes. There is a lot of experience in cardiac ECMO in children. In neonatal respiratory study on meconium aspiration syndrome and other causes, when it was started, there were some groups which have gone for mainly veno-arterial ECMO in the neonatal group because of their experience, and sometimes it could be due to cannula position as well, cannula availability as well. But mostly it was due to the experience. Some centers have gone for veno-arterial ECMO rather than respiratory ECMO, even for respiratory indications. But this was a long time ago, nearly 2 decades ago. Science has changed a lot since then. It is a cardiac ECMO is useful for a combination of right ventricular failure, pulmonary hypertension resulting in left-sided failure, of a hypoxemia, or a combination of all the above as well. But the left-sided failure is usually rare in children. Post-operative support for biventricular hearts. Rarely children with biventricular hearts need ECMO support. This could be a complicated case with another associated abnormality, and inability to come off cardiopulmonary bypass could be an indication in this group, but they usually do very well. Dr. Chaturvedi from Great Ormond Street Hospital at the time, he published this article on survival of children with the biventricular hearts following cardiac ECMO. You can see initially children who needed cardiac ECMO for less number of hours, that is up to 200 hours, the survival rate was much better, and when the number of hours exceeded to 300, then the survival rate came down drastically. Univentricular hearts, this is one of the common group which needs ECMO in our part of the patient group. Patients' anatomical diagnosis and operative procedures are imprecise guides to the reversibility of ventricular dysfunction. Most of the times it is done in a cardiac theater, or when you are watching the patient closely in the ICU with inotropic requirement and lactate like that, we can see the need for ECMO. Then they will be placed on ECMO in ICU itself. So this is one of the children with the 2 cannula as you are seeing there. The top one being arterial cannula in the arch of the aorta, and the second one in right atrium. The tip is not here, the tip is here. This is the tip. So there is a transparent part of the tubing from here to here. So the tip is in the right atrium for venous collection. ECMO is an option for bridging as well, for bridging to decision when it is unclear, bridge to recovery, bridge to revise, and bridge to transplant. Sometimes when they need ECMO for a longer period of time or cardiopulmonary cardiac support for longer period of time, we can transfer them onto Berlin heart, awaiting availability of heart for transplantation. Some of them do get better during this process, but usually it is a bridge for transplantation. In one of these papers on Great Ormond Street, collecting their cases between 1992 to 2000, there are few factors which have become very evident. initiation of ECMO in theater was associated with better outcome. 64% of the cases were better off compared to 30% survival in those who had ECMO initiated in ICU or other places. Better survival in those with reactive pulmonary hypertension. Worse outcomes were those children with circuit problems, renal support, residual lesions, and prolonged duration of ECMO exceeding 200 hours. Another factor with survival figures, individual hospitals do have different survival figures. This is what we use at Leicester, the Levetronics console. In case of bleeding associated with cannulae, we have protocols as we were discussing since the last 2 days. Instigate bleeding protocol and be prepared to pack the chest and re-explore. Switch to peripheral cannulation and close the chest if possible. And the fluid management, we were discussing with other groups this morning, and Vivek has shown the importance of maintaining the fluid balance. In our experience, we had cases which were referred for ECMO but were managed simply with fluid balance, and they didn't need ECMO support. So much is the importance of managing fluid balance to negative balance. So it is extremely important to make sure aggressive diuretic therapy is established, and if that is not helping, early CVVH is needed as well. Decreased myocardial contractility can result in myocardial stun at times. Heart can stop, but in reversible causes, it tends to restart after a period of time. Similarly, we discussed on day 1, if there were malignant arrhythmias while patient is on ECMO, you don't need to treat them, they will get better. If there is a electrolyte imbalance or some correctable problem, you need to treat them, but shocking is not necessary. Altered coronary perfusion, increased afterload are also seen associated with this because of the position of arterial cannula on the way, obstructing aortic output, posing increased afterload to the heart. Studies have shown varying results with regards to myocardial workload also. Most emphasis has to be paid to this fact of venting. As you can all understand, if the myocardium is not functioning very well, or the left ventricle is unable to eject the blood out, there will be difficulty for the left atrium to empty its contents. So that is the reason left atrial distension develops, and when left atrial distension is there, blood cannot come back from the lungs to the left atrium. So that results in pulmonary venous hypertension. So these things have to be meticulously watched, and a vent has to be put in at the right point of time. Vent is not the first point. If you are putting a patient on ECMO in theater, on cardiac ECMO in theater, in those cases it is ideal to put the vent which joins the venous side of the circuit in the first instance itself in a prophylactic manner, because afterwards it becomes a little bit difficult. The medical management is by reduction of the afterload, facilitating the left ventricle to empty in a better way. If that is unsuccessful and you see evidence of pulmonary edema associated with the echocardiographic evidence of distension of left atrium, then venting becomes necessary. The options are by establishing intracardiac communications in the form of atrial septostomy, either balloon atrial septostomy or blade atrial septostomy, or through radiofrequency. The other surgical options are right superior pulmonary venous vent, or we're putting a venting cannula directly into the left atrium. So this picture is showing a venting cannula going across the pulmonary, across the atrial septum, and the other end will be connected to the pre-pump drainage catheter, showing distension of the left atrium in the pictures. We know this. So coming off veno-arterial ECMO, weaning the flows, watching the progress, decannulation as a patient can tolerate. There are two techniques as we talked about yesterday, with insertion of the bridge and without insertion of the bridge via reverse flow trial off. Minimal inotropic support is almost always required when you are trialing of a patient to test if they can cope coming off veno-arterial ECMO. Sometimes you can see the heart has recovered, but the lungs, which were better before, have gone off during this process, maybe as a result of systemic inflammatory response. So in those cases, you can convert the cannulation to peripheral veno-venous ECMO and come off central veno-arterial ECMO cannulation. This happens when the lungs are not ready. So some of the case series here, a neonatal baby, newborn baby referred for ECMO, a 4-chambered heart but PPHN, TAPVC, or total anomalous pulmonary venous connections, is not an easy diagnosis to make always. In the neonatal period, when you see blood not coming back from the pulmonary veins, that can be because of pulmonary hypertension, blood is not coming back to the left atrium, or it could be an anatomical abnormality where the pulmonary veins are not seen to be coming back to left atrium. So all the times it is not very clear. ECMO is an option to support them initially. You can repeat your echocardiogram and cardiac catheterization during this procedure and go ahead with surgical correction if your diagnosis is a surgically correctable condition like TAPVC. Similarly, we had another case, but here it was identifiable on table. So this is part of our procedure as well. Before we put a baby to ECMO, we always do echocardiogram to exclude any treatable congenital cardiac problems before putting the baby on ECMO. The case number 3, there is another case, Alcapa, 4-month-old child. I sometimes consider these cases similar to our TGAs or late presentations of TGAs. When they can't cope very well, that is another time we can think of putting them electively on ECMO, late presentations of TGAs. So Alcapas also sometimes don't do very well, and they can be supported on ECMO for a transient period. But this principle almost holds good. If you see, if you are waiting for myocardial recovery, usually it happens by day 7. Day 7 to day 10 is a twilight zone, but usually myocardial recovery will happen by 7 days. Afterwards, very few will recover. Another case of hypoplastic left heart. This is one of our commonest cases needing ECMO support these days. If they don't cope coming off cardiopulmonary bypass following Norwood stage 1 procedure, or seem to have increasing inotropic requirement with increasing trend of lactate, these are the cases needing ECMO support, and they do reasonably well. Cannulation is veno-arterial cannulation. Either it can be peripheral or transthoracic. If it is a surgical case, most likely it tends to be transthoracic cannulation. But if it is a myocarditis or some cardiomyopathy, it could be peripheral veno-arterial cannulation. So later on, veno-venous could be an option as well. Because of lack of time, we couldn't go in depth about ECPR yesterday, but I will very briefly mention about this. If you have in-house facilities to go onto ECMO, and if your staff can be called within 10 to 15 minutes time to be there and to take the case onto ECMO. That is the time we can initiate ECPR program in your hospital. We can think about that then. So what happens is generally when at the time of a cardiac arrest, resuscitation is started and team is ECMO team is alerted exactly at the same time. They do come in the next 10 minutes and get ready. If the progress is not good enough with conventional cardiopulmonary resuscitation or CPR, that is the time you hand over the case to ECMO team for the ECMO surgeons to cannulate the patient. So we will be cannulating the patient while we are continuing with the cardiac massage. Probably we will leave cardiac massage for a few seconds when surgeons are exactly entering into the vessel, but apart from that, you continue doing cardiac massage during the entire procedure. So the resuscitation will continue and the cardiac massage and other part of resuscitation will also continue. So ideally, if cannulation takes 15 minutes, so by the end of half an hour, you are supposed to be on ECMO. This is the ideal standard. The quality of CPR is very essential for outcomes. Why you are so much interested in ECPR is the outcome of ECPR is close to 44% or 45%, which is nearly the outcome of veno-arterial ECMO or cardiac ECMO. So in view of that, in centers where ECMO is practiced very often, then ECPR is also part of their routine tools. There are more than 700 patients in ELSO registry. Initial study suggested good outcome. As I mentioned, 42% survival. Most of the times, in cardiac cases, this is employed more often than respiratory cases, because if it is out of hospital cardiac arrest and cardiac arrest has already happened for long period of time, unknown period of time, then probably it is less effective. And another condition, another case where it will be effective is probably profound hypothermia. So pre-operative stabilization, I want to be quick here. TAPVC is one, TGA is another condition, refractory pulmonary hypertension. These are the conditions where preoperative stabilization might be needed. TAPVC, that one, and TGA, I mentioned about the indication for going on to ECMO when you cannot easily do your atrial septostomy due to very poor condition of the patient. That is the time we tend to stabilize them on ECMO, either difficult TGS or sometimes, as it is shown here, in a TA, in tetralogy fallow as well, with tetralogy fallow with absent pulmonary valve syndrome. They may need stabilization and ECMO before corrective procedure. The indication here is severe reduction in pulmonary blood flow leading to severe hypoxia. A severely spilling child may be treated with venous ECMO. TGA I mentioned about that, sometimes in Epstein's as well. Okay, we talked about that. Good repair is extremely important, and ECMO gives us an opportunity to revisit that by means of echo, CT angio, and cardiac catheterization. In univentricular hearts, initial results were not good, but as time goes by, it is improving. Currently, the results are around 60% of the outcomes. They do differ from institution to institution. This is a case of Norwood, stage 1, needing ECMO in some of the cases, but with our unit's experience, I can say our center's experience, certainly ECMO would be an option if children are not doing well following Norwood stage 1. When the shunt is there, it can be left open. Shunt only increase BT shunt, for example, if it is there, In those cases, the flows need to be higher. Flows of 150 to 200 mils per kilo per minute may be required due to significant runoff via the shunt to the pulmonary bed. Again, fluid management is very important in these children. Okay, better outcomes are seen nowadays. We have up to 90% survival with improved neurodevelopmental outcome in our series in these cases of hypoplastic left heart. Bidirectional Glenn with hypoplastic left heart, again for the second procedure, they may need multiple venous cannula during this time. Yeah. Post Glenn, if they need cardiopulmonary support as ECMO, early decompression of SVC may improve neurological outcome in these cases. Failing Fontan may also need support with ECMO. Okay, better bladder is a one device as a LA vent also, and just for the sake of emptying the left atrium, you can make use of better bladder. This is even without introduction of membrane oxygenator, as if the lungs are good. So in severe resistant arrhythmias, if they are not responding to conventional management with anti-arrhythmic medications, then transiently they can be supported with ECMO while the definitive procedures are being carried out. In myocardial infarction, neonatal myocardial infarction, we had 4 neonates presenting to us with cardiac collapse, and they were found to show myocardial infarction. I think 3 out of 4 have improved and survived very well. Myocarditis is another common condition we tend to see, could be viral, or in our country it could be secondary to scorpion sting or such venoms as well. In other countries, viral induced myocarditis is seen quite often. If the inotropic requirement is going high, then that is a condition, that is a time we need to resort for support with veno-arterial ECMO. If the underlying condition is treatable, they tend to get better soon. But if it is not treatable, that would be a case where you have to think about support with a mechanical device as well. PDA may pose a problem if there is significant problem needing high pulmonary blood flow, resulting in high pulmonary blood flow and pulmonary edema. PDA can be clipped while on ECMO as well. Intermediary support of prolongation of cardiopulmonary bypass for few hours, as I mentioned earlier, in cases like delayed presentations, that might be of helpful if started earlier. But the modification with ultrafiltration and steroids would be certainly helpful to improve their outcomes. Elevated lactate is one of the very important landmarks for us to see the trend, how the trend is going. It is a sign of anaerobic metabolism. If it is increasing, then that would be an indication for thinking of ECMO support at that period of time. In my experience, I have seen a number as 12 to 14 of lactate or increasing lactate. Both are indications for going on to ECMO support. So it is a team support. As you know, everybody are involved as part of the team in this. Cardiac surgeons, cardiologists, intensivists, technicians, everybody are a team in taking this forward. It is not very easy, but once you are used to doing this, many lives can be saved as a result of resorting to veno-arterial ECMO in cases needed. Thank you. And any questions?